And then also we have Tammy Whalen with us. And Tammy is with the Connections for Health Care Coordination Team, which began as part of the Integrated Delivery Network project. And she worked collaboratively with SOS during the time of her IDN project. And that included coordinating Stratford County emergency warning shelters. She also worked with an organization, LEAD, and community care teams. And so her care coordination team connects members of our community who are experiencing homelessness or transitioning from facilities back to their communities with clinical and social services. So she brings experience in accessing housing and HUD programs, HUD programs, building community collaborations, and implementing community-based care coordination programs. So we have some wonderful expertise on this call. And just to make sure we have enough time to cover everything, I'm going to jump right in and give you an introduction. I'm going to start by just giving you a brief overview of the Substance Use Disorder, Brain Injury, and Mental Health Task Force and what we are focusing on. And then I'm going to pass the baton to my colleagues who are going to go into giving us some New Hampshire data on substance use disorder, and then helping you with some tips on how to recognize the signs of both SUD and brain injury, and then ways that you can help in your role as educators and what resources are available to you. So we formed this task force, and when I say we, I mean the Brain Injury Association of New Hampshire really took the lead back in 2019 with an effort to raise awareness about this relationship between overdose and brain injury and help to change behaviors around those. And although once Crystal kind of goes through her piece and you understand a little bit about why these two things are related, it's not a link that people make commonly. So we got all kinds of expertise together for about 6 months just to figure out a strategic plan and the areas that we wanted to focus on. And that included professionals not only from the Brain Injury Association, but we have representatives from St. Joseph Hospital. We have a retired neuropsychologist, folks from the DHHS Bureau of Drug and Alcohol Services, New Hampshire BDS, retired pediatric nurse, and other community partners. So with that, we decided that the three audiences that we would really focus on would be, first, anyone on the medical front lines. So people like first responders, ER physicians, nurses, counselors. And then next, we would do educators because we wanted to get to that teen audience. And then finally, the family and the caregivers of these patients, because they spend the most time with them and would probably have the best chance to observe any connection between SUD and brain injury. So since developing the strategic plan, we've been able to make some strides in each of these areas. Right now, actually, we are rolling out an excellent pilot program at St. Joseph Hospital, which involves training the providers and the non-providers on how to recognize these signs of brain injury and how to not only document them, but then refer the patients to the brain injury using a tried and true screening tool that was developed by Dr. John Corrigan at Ohio State University. So I'm sure you'll be hearing more on that as the pilot program goes forward. We also developed something that we call a RAC card, which is just a two-sided card that gives the very basic information on signs of a brain injury, how to refer someone who's had a brain injury, what to look for in a substance use disorder patient. And we are happy to share copies of that with anyone that types into the chat that they would like us to email them a copy. Just put your email address in there and we'll take care of that. For the educators, we've actually been working closely with Lisa's outfit, the Office of Social and Emotional Wellness, to provide information on brain injury and substance use disorder for their website. We also developed a separate section on the Brain Injury Association website dedicated to this topic. And we also worked with the New Hampshire PBS folks on their special Roads to Recovery. It was an hour-long special. We got them to trim it back to 30 minutes, thinking that it might be a tool that we use in the classroom. And of course, for family and caregivers, they have been able to access the website from the Brain Injury Association and also the RAC card. We worked with several organizations to distribute those. We worked with first responders and got them inserted into opioid overdose kits that were going to the families and caregivers. And we also distributed them through the public health networks. So that's a little bit about what we've been doing. And let's see, seems to be stuck. There we go. I'm going to turn that over to Crystal, who's going to tell us a little bit about the science behind all of this and help us recognize brain injury and overdose.
Great. Thank you so much, Robin. As Robin mentioned, my name is Crystal Chase. I'm the Director of Programs and Services at the Brain Injury Association, and I've been working with our interagency task force since its inception back in 2019. We started making these connections at the Brain Injury Association. We started getting calls from individuals. So we run a kind of a helpline where individuals can call for information and resources. And we started getting calls not only from people who had experienced overdoses, but from treatment providers who were working with individuals with brain injuries who were kind of struggling to meet their needs within those treatment settings. So we started kind of connecting the dots regarding opioid overdose and how that can cause a brain injury, and kind of realizing in our talks with a lot of different people, different players, that nobody was really making this connection. So really saw it as a big need, not only within the state of New Hampshire, which everybody knows we've been especially hard hit with the opioid epidemic, but just across the country. So we did, discover that some work was already being done on this with Dr. John Corrigan over at Ohio State University. And we've met with him and done a number of collaborative sessions with him. So part of why we're here today is to continue to bring awareness to this issue, especially when we're talking with substance use treatment providers or those of you who are working directly with this population, educators, et cetera, to be able to recognize the signs and symptoms of brain injury that could be a result of an opioid overdose, and then kind of how to then navigate and help guide people in the right direction. So very basic, what is an overdose? I think everybody knows an overdose happens when you take too much of one substance or too much of a mix of substances. What happens to your body during an overdose? Basically, your blood would start to fill with the opioid. It starts to slow your breathing, slow your heart rate, and can eventually cause complete respiratory failure, in which very little oxygen is reaching your brain, which is called hypoxia, or no oxygen is reaching your brain, which is called anoxia. So anoxic, hypoxic brain injuries, we'll talk about those in a second, but those are the result of lack of or complete, so lack of oxygen or just diminished oxygen to the brain. After a few minutes, you can start to have permanent repercussions from that lack of oxygen to your brain. Next slide, please. Okay, so now what is a brain injury? I think a lot of individuals are familiar with traumatic brain injuries. There's been a lot of focus on TBIs over the last 10 or so years, as it relates to youth sports and football. So a traumatic brain injury is caused by an external factor. It's caused by a bump or blow to the head. Also, obviously with the return of the Iraq war veterans, we saw an increase in individuals seeking support for traumatic brain injuries related to their experiences there. So I think we're pretty familiar with TBIs. Acquired brain injuries are less talked about as far as, these are your strokes, your brain bleeds, things that happen internally in your brain that you may not consider a brain injury necessarily, but fall under the acquired brain injury category. So ABIs happen after birth. They're not as the result of anything that happens during birth trauma, or anything perinatal or congenital or hereditary. So anything happening after birth, things like seizures, strokes, infectious disease, brain bleeds, those kinds of things, those fall under acquired brain injuries. Anoxic and hypoxic brain injuries also fall under this acquired brain injury category because they're not as the result of an external blow to the head. So like I mentioned, lack of oxygen to the brain for 3 minutes or more can result in brain injuries. It can happen even sooner than that. It really depends on the person, but 3 to 4 minutes is what experts generally say is when permanent brain damage can really start to set in. Next slide, please.
Sorry, I'm having a little bit of a difficult time.
Thank you. So brain injuries can run from mild to moderate to severe. And this is true for acquired brain injuries as well as traumatic brain injuries. So when you have a mild brain injury, you may have some lasting effects, but they're not going to be as permanent or maybe as severe as experiencing a severe brain injury where you may end up in long-term coma, as a result of complete loss of brain function. Part of what we've seen with the use of naloxone or Narcan, which obviously we're in support of that being readily available and widely distributed and easily accessible to people. But one thing that we've noticed is that individuals who are using Narcan in the field, maybe using with friends and somebody is carrying Narcan, is that once you give Narcan during an overdose, you survive the overdose and everything is fine. And it creates this false sense of security that using Narcan reverses the overdose and you won't end up with any long-lasting brain injury symptoms. But that's not true. So one thing that we've seen is that individuals will receive Narcan in the field. They'll be brought to the emergency department for further monitoring. And once they're in the emergency department, they don't always want to stay there. And they may leave, and the effects of the Narcan wear off and they can go back into respiratory depression and continue to experience lack of oxygen to the brain. So you always want to be seen by a medical provider after you have received Narcan for that monitoring. And part of that process is monitoring your oxygen levels and how much oxygen is reaching your brain. One thing I was going to say on that last slide was that thanks. Brain damage, brain injuries are cumulative. So they just get worse over time the more brain injuries you have. So if you have multiple concussions, they just continue to build upon each other. And that's the same with opioid overdose. So the more revivals that you may have related to Narcan, the worse your brain injury symptoms may be over time. And we've seen that firsthand. It's been reported to us by individuals on our task force that work in the emergency room who have been doing that for a while, seeing folks come in after the first overdose, second overdose, and third overdose, and really over time noticing a very steep cognitive decline with some of those individuals in their ability to retain information and engage in participate with the treatment team at the hospital. Next slide. Okay. So signs and symptoms of a brain injury. One thing that we always say at the Brain Injury Association is when you've seen one brain injury, you've seen one brain injury. Everybody is so different as far as the types of symptoms they may experience and the severity of those symptoms. Even if you have, the exact same thing happen as somebody else next to you, your signs and symptoms could be very, very different. One thing also that to keep in mind is signs and symptoms of a brain injury can also mimic signs and symptoms of active substance use. And so sometimes individuals may be experiencing these signs and symptoms and that may be falsely attributed to them using substances when that's not the case. So some of the most common signs and symptoms of brain injury are mostly related to executive functioning. So difficulty learning and remembering, decreased attention span, mood instability, mood changes, depression, anxiety, which, as we know, can lead to increased substance use. One thing to know about brain injury and substance use is that there's always been a very clear link between individuals who use substances and individuals who have brain injuries. And part of that is, either pre-injury they were using or drinking, and it may have caused the injury or led to the injury in some way. And then post-injury, they may continue to use or to drink to cope with some of the symptoms that they're now experiencing and the major change in their life that they've experienced as the result of this injury. Feeling overtired, headaches, changes in vision. So there are specific neuro-ophthalmologists that are out there that work with individuals who have vision changes as the result of brain injuries. That's a very common thing that can occur. And some of the more challenging symptoms that are signs that you might see with someone with a brain injury are things like impulsivity, behavioral outbursts, inappropriate conversations or language. And sometimes those things can be very disruptive to individuals around them, which, it makes people less receptive to trying to help those individuals because of some of those challenging behaviors that they may come up against. Next slide, please. Am I doing this slide? I can't remember. I can do it. So like I said on the last slide, signs of drug and alcohol misuse can mimic signs of brain injury. Can also mimic signs of trauma or complex grief. So it's really important to, in the individuals that you're working with in whatever setting that might be, is keep note of the signs of brain injuries, especially if you know that somebody has had multiple overdoses, and watch for some of those things that we mentioned. You want to refer individuals out for further evaluation. You don't just want to chalk it up to, this is a brain injury. And, although it may be very evident that that's probably what you're dealing with, you definitely want individuals to be evaluated by professionals. So typically you would refer them either back to their primary care doctor, who may refer them out to a neurologist. And that's usually the best course of action for somebody to be evaluated for if they are experiencing a brain injury, and then kind of move forward with the appropriate treatment. And one thing that we've seen, and I think everybody, has been aware of this, is with the pandemic, with the increased isolation, all of the craziness that's going on around us has resulted in increased drug and alcohol use kind of across the board. And then you also have the risk for increased overdoses when you have people who are using substances at a higher frequency. You also may have reticence to accept medical treatment during the pandemic, just not wanting to jam up the hospital system, or, just not feeling like you want to expose yourself in a hospital environment. So that is one thing that we've heard as well, is that people are experiencing overdoses at higher rates, but maybe seeking medical treatment at lower rates.
Thank you. And I believe, Tammy, this is where you step in.
All right, thank you. Thank you, Crystal. My name is Tammy Whalen, and I am from Connections for Health, which was formerly part of an IDN project. We are located in the Dover, Rochester, soon to be open Portsmouth and Hampton SOS centers. We've moved over there to do our community-based care coordination and case management in about June of this year. So going back a little bit to what Crystal said with the signs of drug and alcohol misuse, we work in the community, and what we do is kind of get referrals from other clinical and social service providers and try to do a little bit of detective work to figure out maybe why folks are falling through the cracks in the system, why they just can't seem to make connections. And we've seen an increase in the number of folks that are presenting with brain injuries, but that also overlaps with mental health, trauma, grief, a whole lot of other issues. And it's really difficult to try to tease out which ones are which. So as Crystal had said, there are some some examples of what people are going through, like their behaviors, their shifts in mood, low motivation and productivity. They become lose a little bit of lack of self-control, become more impulsive. And those are the things that we're really listening for when we're talking to the providers and the clinicians for the folks that are having a difficult time. Some of the things that we try to do within our care coordination groups is to speak about people with a person-centered language. So talk about the person and not about judgment of how they use substances or how many times they've had to be revived with Narcan. It takes as long as it takes. And that's kind of how our belief system is, that we just keep going with people and we hold hope and try as much as possible to model how to care for people without using stigmatizing language. Harm reduction is absolutely a tool that is essential. This is where the Narcan, the naloxone, you've heard of those with the nose sprays that have been out in the community, and that's what's keeping people alive. And that's really what we want to do, is keep people alive so that tomorrow they have an opportunity to go in and work a little bit more on their hopes and dreams. And then the last thing I would really share about what's important with this work that we're doing is to be a champion for people. If you have a client, a friend, a neighbor, a student, if you can be that person, you don't have to solve all the problems, but just being that one person that can advocate for them, because there's so many difficulties with people kind of being able to keep that motivation to keep going, and dealing with doctor's appointments can be so overwhelming. For those that don't have brain injuries, if you're struggling with a lot of these issues, it makes it that much harder. So just really being somebody that can have extra eyes and ears to say, you know what, this doesn't sound like this person that I've known and loved for a long time, or this isn't the client that presented to me a while ago. And I'll give you an example of that, of what we did in our community care team. So we have about 60 or so social service and clinicians that are part of our kind of hospital-based team. So we're out of Exeter, Portsmouth, and in Stratford County. And we had one gentleman that was brought to our team. He was probably 18, 19. So the person who presented him had just said, you know, this young man is really stuck. Anything that we try to get him connected to just doesn't seem to be working. But he says that he wants to get a job, but just doesn't seem to have the motivation. He was using a lot of substances. He was smoking a lot of pot, and he just seemed to just be stuck in this space where he couldn't move forward. So our team had gone out, because we are community based, and we would go out, we would go and meet with people. And at the time we were working with a substance use navigator, somebody who was able to kind of understand what the treatment options were and could kind of build that rapport with folks as they work through the process with them. So we met this young man, and it was really interesting because one of the things that he had said was that he had been in a car accident, that he had been drinking, and it was underage drinking. I don't think the driver had a license. There were some other issues. So when the police came, he was very, very nervous about the trouble he was going to get in. So he chose not to have himself checked out by any kind of doctors, didn't want to go to the hospital at the time because of those things. And that kind of stuck out in our minds of like, okay, here's somebody that was doing really well in school, had a great athletic career, had friends, and now he's sitting alone, can't seem to move forward. Family had to set some boundaries with them and say, you know, you can't stay here, you can't live here anymore. And it was that accident where there was a potential brain injury that kind of stuck out. So we were able to bring that information back, and then as a team, try to do a little bit, you know, put on our Columbo hats and try to figure out, all right, well, what can we do next? What's working, what isn't working, and how can we get this person connected? So he was able to get a neuropsych exam, which was scheduled way out. And for anybody that is struggling with a brain injury and even mental health and other issues, when you have something that's that far in the future, it's going to be really hard to remember on their own to get to those appointments. So we built a very strong wraparound team to make sure that this young man could get to that appointment. But it was just really frustrating that this kind of care and services all were going to be pushed out. I mean, we were looking at like 3-4 months at the time, which doesn't seem so bad because now during COVID, it can be even longer than that. So just being patient with people and trying to, just kind of keep eyes on those kinds of things. So, and making sure that they don't fall through, because had he missed that appointment, it would have taken, almost a year or more to get him just that one step. So that's just kind of an example of how we were able to work and how it took everybody coming together to have a discussion about this young man and pull those pieces together. None of us were responsible on our own to diagnose or to treat it, but just as a collective group, it really made a difference in this young man's life. Okay, next slide. Stigma is, as I mentioned, this is really important because this is how we build relationships with people, and this is how we can reduce that shame and blame about someone's situation. And it's looking at, I said, person-centered, person-first language. It's looking at somebody as they are the experts on their own lives and respecting that. So it's treating people as, okay, you don't want to go to the doctor. He didn't want to go to, this young man didn't want to go to the hospital at the time. I understand his fear. Had we had some connection with him at that time, probably would have tried to do a little more with following up with a primary care, somebody a little bit sooner, because it seemed like it was about a year and a half about a year and a half between having that accident and when these symptoms really seemed to be noticeable to the point where it was interrupting his life significantly. Okay, next slide. So when we're looking at our statistics, we have, when we're looking at our statistics, there's a lot on overdose deaths. And we know in New Hampshire, it's a mess. There's a very high number of people that are using opioids. And that's why we talk about harm reduction and brain injury with people that use heroin, fentanyl, and other opioids, because it's so easy to overdose on those drugs. Next slide. So this is really important because this is a list of the response for Narcan. So this is not people who have died from an overdose. These are the non-fatal overdoses. And just looking at it, when I first saw this, I thought that it struck me as the opioid epidemic is hitting almost every corner of our state. And if you look at the towns that don't have any, these are just the ones that are reported. So these are the ones where somebody called 911 and they were seen by an emergency response team. This does not include the people that have Narcan in their communities and were able to reverse an overdose that did not call 911, which happens a lot. Those numbers are not captured as well. So as we're talking about brain injuries, knowing that they're related to overdoses, this is a whole lot of people that have been able to live another day, to think about how it is that they might want to proceed and make their dreams come true and live life the way that they want to. But this affects everyone in the community. We've got, neighbors, parents, classroom kids and their families, and it affects everyone. Next slide. And now I will turn it over to Lisa. Thank you.
Thank you. So every 2 years, the state of New Hampshire, in fact, all states in the United States, have got the opportunity to offer in schools and launch a CDC survey called the YRBS. And YRBS stands for the Youth Risk Behavior Survey. And this survey that schools can voluntarily participate in grades 9 through 12, monitors 6 types of risk behaviors that contribute to the leading causes of death and disability in youth. And one of the indicators in the YRBS is related to drug and alcohol use. And students essentially self-report their experiences of drug and alcohol use through very specific questions. So we have got in New Hampshire access to the data from the 2019 YRBS. And one of the questions that was asked by the CDC to students in grades 9 through 12 are, were you offered, sold, or given an illegal drug on school property during the 12 months before the survey? And as you can see on this slide, 22.8% of male students said yes, they were offered, sold, or given an illegal drug on school property. 20% of female students responded yes, for a total of about 22%. So 22% of students in New Hampshire schools, grade 9 through 12, disclosed that they were offered, sold, or given an illegal drug on school property during the 12 months before the 2019 survey. So that's a significant number of students, of youth in New Hampshire who have had access, whether they accepted it or not, we don't know, to drugs. And as we know from Crystal, Robin, can you progress to the next slide, please? We know that once students start taking drugs, they have an increased risk of brain injury. So additional statewide statistics for students in New Hampshire schools are, we know that teenagers in New Hampshire are nearly 30% more likely to have used drugs in the last month than the average American teenager. We know that about 16% of all 12 to 17-year-olds report using marijuana in the last year. That would have been in 2018, because that's the most recent data we have. 1.6 report using cocaine in 2018. Up to 5.3 report that they used methamphetamines, and we've got limited data about that. 0.53% of students have used heroin, and 2.13 report misusing pain relievers. Now, of these categories, I was talking with our expert, Crystal Chase, on this, and she said, with the exception of marijuana, all of these substances can cause an overdose. And that overdose, as we know, can lead to brain injury. So, Robin, can you progress, please? So one of the concerns that we have is, how can we help those students? How can we help schools? What can we do within New Hampshire schools to help these students, A, get the treatment they need, but also prevent brain injury, which we know is linked to their academic success and then their success after they graduate and proceed to higher education or career. We encourage all of our educators and parents and community members to recognize the signs of a brain injury. You don't need to diagnose. It's not, none of us can diagnose anything. We're not neurobiologists, but recognizing some of the signs of brain injury allows us then to bring the information forward to a school counselor, to a clinician at school, to a school nurse, to an intervention team, so that the student can receive the support they need. Also recognize the signs of potential drug or alcohol misuse with students that Crystal referred to. And we at the DOE have got a fairly large website with resources available for educators and for students and parents about brain injury and SUD. And of course, we've got the Brain Injury Association webpage that Robin has put together. So what we want you to do, if you're working in an educational environment or you're touching the lives of students in any way, is to be aware that that 20% of New Hampshire students report, this is what they self-report, that they have had access to drugs that can cause brain injury. So Robin, can you progress? Because I think we're coming up on time here and we're rushing through. So I think I'm going to turn it over to Robin now to talk about some of our resources that we can share with you after this session via email.
Yeah, and I think some of the resources you mentioned, we can make this PowerPoint available to anyone who would like it, so that you can spend some time clicking on these links and getting some of this information. But I think importantly, it would be nice to have some time now. I'm going to leave this up just in case people want to, take down anyone's email addresses, but I would love to hear from some of the folks out there who are in the schools and working directly with students, any questions you have. And in particular, I'm really interested in some of your thoughts on what would be effective tools beyond the tools that we've described that we have for you as educators in the classroom, what are some things that the task force or the Office of Student Wellness and Health could focus on that would be most helpful to you as you try to educate students about the dangers of some of this stuff? I'd be curious to either, if you can type it in the chat if you want, or disable your mic or your mute button, and so that we can actually hear you. If anybody has any thoughts on that. And while we're waiting for people to come up with any questions they have, I think one of the things that has occurred to me as I've been working on these projects and sitting in on conversations about teens and drug use, I was pretty shocked to find out that there are lots of other over-the-counter, there's lots of access to over-the-counter things like Tylenol PM, which taken in excess can shut people's organs down, and the Benadryl. And I don't know if anybody out here is familiar or has heard about, these YouTube videos and TikToks that challenge the Benadryl challenge. Some of this stuff that's out there that is, provoking teens to engage in some of these dangerous behaviors. I don't know if any of the educators want to comment on that, or anyone on the panel want to address that at all, but it is something to be thinking about.
I would just add that sometimes teenagers and youth take substances for a number of reasons, and sometimes it's to self medicate their feelings of depression and anxiety. Some genuinely have addictions, and some of them, like Robin is saying, see a TikTok video and they think, oh, I can try that, without really thinking about the long-term repercussions on what they're doing. So there are a number of reasons that students could be taking any substances.
Yeah, I don't see any questions in the chat, but a few people have mentioned that they would like to have either the rack card or the PowerPoint, and we will absolutely make those available to folks. Any additional comments from our panelists, things that you want to add that perhaps you forgot to say while you were giving your part of the presentation, Crystal?
I just wanted to mention, we talked about the Brain Injury Association website. So I just wanted to mention it's BIANH.org. You can access, all kinds of stuff there, but there is a specific tab. If you go to the resources tab and scroll down the bottom, you'll see substance use disorder and brain injury. And we've put together a number of really helpful resources as far as treatment centers that might be willing to work with individuals with brain injuries, all the way to what we had talked about with our work with Dr. John Corrigan and the screening tool to identify if somebody might have a brain injury. So there's a number of really good resources on there. And if you have any other resources that you think might be helpful for us to share, please feel free to email me directly and we can try to get those on the website as well. So we're always looking to expand that section and provide more information to folks. So if you have anything that you think, might be helpful for that, definitely reach out.
Absolutely. And as part of our awareness raising, we are also going to be doing more speaking on these topics. We are addressing various groups and organizations. So if you found value in the presentation today, and if you say, boy, I think that would be good for a parent teacher organization or any other organization that you're affiliated with, we would love to hear about that, because we are going to be proactively seeking opportunities to give this information out. It's very important, and it could really help steer a student in the right direction early on much as the example that Tammy gave when she talked about the young man that just, you know, wasn't himself, and it comes out that he's had a car accident, and sure enough, that is one of the ways you can give yourself a brain injury. So any thoughts on that? We would absolutely be all ears on that. And the last slide has everybody's contact information. I'm going to capture in the chat anyone who has requested for us to follow up with them and provide that information. But if nothing else, I think thank you very much for tuning into this presentation, and hope you enjoyed the rest of the conference. And please feel free to reach out to any of us if you have additional questions or thoughts. So thank you.
Thank you.
Thank you, everyone.
Thank you.